So I think it's 1 o'clock. We're going to start. Dr. Reitan Ribeiro is an associate professor in the Departments of Obstetrics and Gynecology and Oncology at McGill. He's also an attending gynecologic oncologist and surgical oncologist at the McGill University Health Center, the MUHC. Dr. Ribeiro earned his medical degree in Brazil and specialized in gynecologic oncology at Erasto Gertner Hospital, where he later served as research director and director of the robotic training program. A pioneer in laparoscopic and robotic surgery, he developed the uterine transposition technique, an innovative approach that preserves fertility in patients undergoing pelvic radiation. His innovative contributions to surgical oncology have garnered prestigious awards and international recognition, significantly advancing treatment strategies and improving patient outcomes in gynecologic oncology. The title of his talk is Surgical Innovation in Cancer Treatment. Dr. Ribeiro, thank you very much.
Thank you so much. It's such an honor to join you, and I really enjoy being here. And it's a really interesting topic to talk about. It's a very complex topic, but I'm gonna try to show what's happening, how we got there, and why we are doing the things we are doing, and where things can get better, and also some feedbacks of how we all can do innovation in our fields with the things that we already have, and that's quite important. So I have no disclosures for this particular presentation, so I'm going to show lots of companies. No, none of them are giving me anything, so don't worry. So I'm going to go through the history of the innovation in surgery, how we got there, and the present, what we are doing, the near future, and the things that I think they are a little bit too far in the future, and probably I won't see them. And then I'm going to just give you some feedbacks how you may innovate in your field now without needing, for lots of fancy or new things to be developed so you can innovate. And the basis for modern surgeries, they are deeply attached to minimally invasive surgery. And surgery didn't change much for more than 2,000 years until we start to, entering abdominal cavity or entering the bladder or, any kind of natural entrance of the human body. And it started during the Industrial Revolution in the 19th century, when this French guy decided to take a couple of meters, put a candle and illuminate inside the bladder. So this was the first cystoscopy. It was in the 19th century. No big technology, no nothing, because they want to get rid of stones in the bladder, which was quite common back then. So the only problem with this particular equipment, it's because of the candle, it heated, and many patients were burned because of it. So you can see there is a chimney where the smoke came out and there was heating. After him, still in the 19th century, Adolf Kussmaul, he was a very famous doctor. There are signs named after him, and he did the first esophagoscopy in a patient, in a swallow patient. So it was the first time someone saw inside the esophagus of a patient using a tube. So again, we are moving towards ways of achieving abdominal cavities and all sorts of organs, going through them without needing incisions and all that. But the first big change happened for us in surgery when we started doing laparoscopy, which means getting into the abdominal cavity and using a scope, which is like a small cannula with a set of mirrors that you can look inside the abdominal cavity. Back then, we are using air, just compressing air. You can see in the picture, they are pumping air inside the abdomen so you can have distension and look inside. And back then they were looking for tuberculosis, for carcinomatosis, and other things. There were no way to diagnose without surgery. So, but this was how laparoscopy started. Well, we had two wars. Uh, the development of surgery was mainly related to trauma back then. But there was this Frenchman, and even during the Second World War, while French was invaded, he used to take his bike and go to the outskirts of Paris and get carbon dioxide, and he started to insufflate his patient's abdomen with carboxy not with oxygen and nothing and not with air, because when you try to cauterize inside the abdomen with oxygen, there were explosions. So he figured, well, I may use a different gas, and he set it also how much pressure I can use and all that. So he made like the basis for laparoscopy. So modern laparoscopy relies pretty much on how Palmer's discovers about how much pressure, what's the best gas you can use, and all that. So now we have a set of optic instruments, and we know how to enter the abdominal cavity. Then we started to do like small organ resections, and the first organ to be resected were the tubes, and it was a Brazilian guy from southern Brazil, small hospital in the countryside, and this guy started to do salpingectomies. After him, a German gynecologist was the first person to do an appendectomy. And this is also one thing that you need to be careful when you are going to present your achievements, because he decided to present his achievement, his appendectomy, in a general surgeons congress, and it was a disaster. They even say that he needs to be to jail because that was illegal, and it was like something that you should not do. It was a gynecologist doing an appendectomy. And they also questioned how he did it using laparoscopy, that wasn't safe, and all that. So, and also this guy, Kurt Sam, he settled the basis for the instruments that we use now. So all the instruments you see in laparoscopy, I would say 80% were made by this guy. So he had all the patents, and that's why Germany was ahead of many of the developments in minimally invasive laparoscopy until very recently because of him. And then he published, and he tried to publish in many different journals, including the American Society of Surgery, and they rejected his paper about appendectomy. And then he published in a German journal. But still back then in the 80s, the main problem with laparoscopy was that you needed to see through a small cannula. And there was just one, sometimes two people could see at the same time, but it was very hard. So you need to, use your own eyes to see through the scope. And then this was the big revolution regarding laparoscopy, because back before we started using cameras, to capture the image and put it in a screen, it was so hard to perform those procedures. So there was just a little number of crazy surgeons trying laparoscopy. But once we started like recording it and taping it, and they started to have these meetings where people exchange tapes about surgery and all that, then there was this boom of laparoscopy. Once we put the camera, and now we have very small cameras. Back then they were like 3-4 kilograms, so difficult to use, but still laparoscopy started that way. And finally, again, a gynecologist was the first surgeon to perform a cholecystectomy. But this French guy was much smarter, Philippe Mouret. He decided to present the first cholecystectomy in a gynae congress, and they loved it, and it was a boom. And so when you choose where you're going to present your innovation, choose wisely. And he went to a gynecologist where his friends were there and all that, Gynecology Congress, and it was a blast. And right away, people start performing laparoscopy. And then the number of laparoscopy during the 90s the laparoscopy just took over most of the procedures, abdominal procedures, and also thoracic procedures. And you have to imagine that in the 90s and in the 80s, the equipment wasn't that good, but there was a major improvement. And now the equipment we have is way better. So you have such a beautiful image, and the quality is so good, and you can have all that in pretty much everywhere, and it's not that much expensive. So that's what we saw. It's this revolution changing surgery from something from open to laparoscopy procedure. So that happened in the 90s and the early 2000s. And it's pretty fair to say that there is maybe 5% of the procedures need to be done open nowadays. And I would say 95% of the procedures that we used to do open, now they can be safely performed by minimally invasive surgery. Sorry. As you can see here, this is a big tumor. This is a 10-centimeter mass. It's behind the aorta. Those traditionally were surgeries where you'd like do a midline incision, big incision. And now you can do it with MIS. And we have all these fancy instruments that coagulate and cuts at the same time with very minimal bleeding. So that's what happened in the beginning of the 2000s. And then laparoscopy just took over. And there are obvious benefits. You can say, well, there is this cosmetic benefit, which is obvious. There is not easy. It's easy to confirm. But I would say we also decrease the use of drugs that we need to give an analgesia for the patient. They recover much faster. They walk hours after the surgery. Patients that went through laparoscopy, they can walk. And we are saving lots of money because they don't stay at the hospital much. So that's what modern surgery became. At the same time that we were seeing this evolution through laparoscopy, there was a revolution happening for robotics too. And but in the beginning, robotics it wasn't set for the things we are seeing now, because obviously things when you have an invention, it's not sometimes they use for a different purpose. But DARPA, which is the American agency for developing new research and technology, and usually it's related to defense affairs, they were thinking this was you need to understand this is also in the middle of the Cold War. So they have all these space programs and things like that. And they wanted to use the satellite network and all the network they were building for this Star Wars to do surgeries in the battlefield without the surgeon. So what they were trying to do is build a robot that could do open surgery, not laparoscopy, but open surgery in the war field and not in the hospital. That wasn't the idea. But soon enough, they realized that doing surgery, there was a delay from the missions. It was not easy. The setup was very expensive, and they realized that's not gonna be useful at all. And they decided to sell all those patents. And then this guy, which bought all the patents from the DARPA, and he started this company called Intuitive. So he took all the patents for robotic surgery using open instrument, and he said, well, as in surgery is moving towards minimally invasive surgery, so I need to use these patents and make, like minimally invasive surgery using robotics. And that's what he did. And he created this big company that's a huge success that that's Intuitive and the Da Vinci and all that. So it's not been long. It's been 25 years now. You can say that robotic surgery is something quite new in medicine, and it's expanding. And they bought all those companies that were also trying robotics, and they put it all together, and they combined those companies and created Intuitive. And now what we see is the evolution of this machinery, but it's still a very human process in the sense that the robot doesn't do the surgery by itself. So it relies entirely in human knowledge, human abilities, everything. It's just a way to mechanize and to help you and give you precision, but it's still a human process. And that's where we got now. We have this MIS evolution. We have all this robotic technology that is helping us to improve the things we are doing. So I'm going to give you an example that what we are doing now and how precise we can be. This is a tumor that recurred in the pelvis of a patient with endometrial and rectal cancer. So you can see this is the rectum, and you can see this is the ureter. The tumor is in over the sacral roots, so the nerves that are going to the patient's legs. So those are the vein. This is very deep in the pelvis. It's so hard to reach those parts with open or even regular laparoscopy. And these that you see here, those are the nerves that are going to form the lumbar plexus and the sciatic nerve. So the patient depends on them to walk. And what you see, this is a sacral root, this is S3, and we are opening the epineural, which is the external part of the nerve, and resecting a part of the nerve and preserve the internal fibers of the nerve. And that's something that you could not do before. So now you can see, and the image is close, and trust me, the image that the surgeon is seeing during the surgery, it's way better than this one you are seeing now. And now we are resecting part of the muscle, and we are extracting the tumor, and that was impossible before we had this combine of minimally invasive surgery and robotics. So now we can go so close and with so much precision that it was impossible maybe 5 to 10 years ago. So that's what we are doing now, and how precise it got. But I know lots of people say, well, Reitan, I know that there are many trials saying that, well, robotic surgery is not that good actually. And when you compare to laparoscopy, the results can be quite the same. And that's true. And there are a few reasons for that, a couple of reasons. Usually those trials were done 10 to 15 years ago because you need to evaluate, you need to see patients for a long time. It's the learning curve for robotic surgery, so you need to consider that. And there is no much difference in complications and all that. And I'm using here one Cochrane reviews with considering radical prostatectomy, which is like the main procedure for robotics. And when you compare to laparoscopy, actually it looks quite similar. It will change over time. And there's one thing that is happening now with robotics that is changing, which is, as I said, robotics still a very human process. I know it sounds weird, but robotic surgery is still a very human process. It relies on the humans. So what I'm going to show you now, that's a para-aortic lymphadenectomy. So we are removing the nodes around the aorta. So the red thing here, this is the aorta. And you're going to see a scissor coming in. So there is an assistant beside the robot. It's putting a scissor. He's putting the scissor in the robotic arm so the surgeon can use this scissor during the procedure. So you can see there is a 4x4. You can see the aorta. We are holding the colon. Now it's the scissor coming in. And then you see he pushes the scissor inside the aorta. So what I want to show you that robotic surgery is still a very human process by now. It will change over time. So when I put like side-by-side procedures done by laparoscopy or robotics by very experienced surgeons, they look very similar. They are not so different. Well, robotics, it's more stable. It can be a little bit more precise. But in the end, for most of the procedures, when I compare robotics and laparoscopy, they are not that different by now, because now we are seeing the revolution of the things that are being added to the robotic platform that are going to change the surgery in a meaningful way. And here you're going to see one example of them. So we can see things with the robotic platform that we cannot see with the human eye. Let's say infrared light. So on the left side, you can see when we add infrared and we add a dye that can in the lymph nodes, that can accumulate in the lymph nodes, I can find lymph nodes. Even throughout the tissue, I can see throughout this tissue with the robotic platform, and I can see where the lymph nodes are, even before opening the spaces, even before seeing the node, I can see where it will be. And that can be done when you start adding new technologies to the robotic platform. And another important thing is, in the past 5 years, what we see is different new robotic platforms coming to the market. This is a Chinese one. Looks pretty much like Intuitive, I know. It's maybe a copy. But the thing is, there are more, I think, around 20 different robots worldwide. There are new ones in Japan, Korea, China, Europe. So we're going to see more competition. Things will get faster now. Obviously, you have the mechanical benefits of robotic surgery because it can filter the tremor and you can see very close and all that. But you can also do with laparoscopy if you really think about it. But the thing with robotic is using mechanics, you can use single incisions and enter the body of the patients with a single incision. You may put like 3, 4, 5 different instruments. That's something that we cannot do with laparoscopy. So what we see more and more now is also robotics going in this direction, like doing single port, single incisions, and entering the body of the patients through natural orifice. Like we can use the vagina, we can do an incision and enter the vagina with multiple arms and perform any kind of abdominal surgery without an abdominal incision. It's still a human process. You still need to operate the patient, but now you are removing like the abdominal scar. You don't need to have complications related to abdominal incisions. And the instruments are getting better faster. So what we see now, it's lots of new papers coming with this kind of incisions, just a single incision. And actually, Intuitive have been selling those machines worldwide now for maybe 4 or 5 years. So we are seeing more and more. And also there are other platforms because now we can have those arms that can bend and you can even do surgery against your own robot. Let's say you can enter the vagina and you can work anywhere inside the abdomen with different platforms. If you think about what I just spoke about infrared light, and that's a very interesting insight for those of you who are doing research with antibodies or any drugs that can accumulate in specific parts of the body. If you can have like conjugated antibodies that have those dyes that can be generate like fluorescence with infrared light, you can mark any kind of tissue or any structure in the body. So that's something that you can combine now. You don't need to wait. This is something that we can do now. Let's say if you have an antibody that can bind to nerves, you can dye nerves during surgery. You can help the dissection and all that. So that's something that you can do with robotics. We kind of do it with laparoscopy too, but it's not that good. And the robotics are getting more and more, and we are having different source of imaging combining with the robotic platform. Another thing that we use those dyes is to check blood flow. Let's say this is a colorectal anastomosis. This is the rectum. This is the colon. And we want to see if there is if the blood supply of the anastomosis is good. So you want to be sure you have a good anastomosis. So we can inject the dye intravenously, and with the robotic, we can see if there is perfusion. So it means if it gets like green, it means you have blood flow in that part. So you can check for blood supply. And that's something that we use very often in robotic surgery, is to check if the tissue is healthy enough or if you need to remove it. And we use it, I would say, in a regular basis now. And it's done with Indocyanine green. That's not something new. That's something that the ophthalmologists have been using for decades, and now we are using with robotic surgery too. Something that is increasing use too is combining, and that's something that you just can do with robotics now, is using different images from the patient's inside. Like you're doing a robotic surgery, you can put an ultrasound inside, and you can see the ultrasound of the patient in real time while you are operating. So you can take those critical decisions during surgery. So we see those different technologies being combined to the robotic platform more and more. There is something that people were very excited about. It's like distance, like doing surgery at that distance, which was the original idea from DARPA when they started the robotic program. But like communication in the 80s wasn't that good. But now with 5G technology, you can do surgery from different parts of the world. That's fine, that it works. But we know in the practical sense of things, I don't think that's quite useful. Most of the places, when you have a robot, you have good surgeons too. So I don't feel like that's something that's gonna be major thing in surgery. We still rely, what may happen is mentoring. So you may go in another console, in another hospital, in another part of the world, and you may help to do a procedure, a very specific procedure in other parts. But other than that, probably that's not gonna be a big player in the surgery world. Well, and what's next for surgery? So what's happening in, I would say, the near future? Well, robotics and technology are pushing through three main things now in surgery, which is real-time visualization. It means I want to know during surgery if I'm removing the entire tumor of this tissue, is this tumor or is this normal tissue? And I want to be precise, so I want to know where it starts, where it ends, and I want to be informed. I want to during surgery, take the right decisions based on the things I'm seeing. And there are, I would say, three main technologies that are being used. And one of them is augmented reality. So now we can do a body scan of a patient. We can extract the data from the CT, by instance. So we can have the internal anatomy of the liver. Then we can mark the external parts of the imaging, and we can use the external view of the image and use it inside the patient at the actual organ. Let's say, so I do all these marks, and then when I go to the surgery itself, what I can do is superimpose. It's like take the image from the patient. The robotic itself will use a fusion, and I will put the CT scan of the patient over the organ itself, and you can see the pink dot is the tumor, and I can see, well, the tumor is right there. So now I can see through the organs itself, and you can see that when you mobilize the organs, the structures they mobilize to. So this is real-time surgery. So you're taking real decisions. You are making decisions based on the patient's anatomy, patient's preoperative exams, and you can do it during surgery itself. You don't need to extra equipment. You're just building something using the robotic platform. Another very interesting concept is, well, if I have an image and I have something that is moving, and if I can stabilize this image, I may be able to make the robot move with the image. So when I'm looking as a surgeon, I will look to this image and it will look like it stopped. So the arms of the robot can correct the movement, and you can do like very stable movements. That would be great for cardiac surgery, for instance. So you won't need like to stop the heart of the patient to do like a vascular anastomosis or a bypass or something like that. So if you can stabilize the image and make the robot make the same movements the heart is making, then it will look like everything is stopped to you, and it's going to make much easier to do some procedures. This is another thing that is increasing in use. It's still experimental, but I think that's going to be soon available. It's called hyperspectral imaging. And basically, it means when you look at something as humans, we see this combination of colors. We call like the blue, the green, and red, and the combination of them. And then you just see one color. And obviously, there is like variation of those colors, but still, you have just one image. But when you see it, you don't know how much green there is, or how much red there is, or how much pink or brown, and all the spectrum of the colors. What they are doing now is they have different lights, and they use different lights to each tissue and examine how much of each spectrum of the colors that the specific tissue has. It means every tissue has a footprint, has a fingerprint print, and a specific spectrum of the light. And you can build graphics and know just by looking at it what's like the composition of that tissue, or are those like tumor cells, are those normal cells, because they have different spectrums in this hyperspectral imaging. So let's say I'm doing an endoscopy and I see any kind of area that doesn't look normal. So I can do this scan of that part of the mucosa, and you come back with a signature, let's say, a light signature with different wavelengths. Some tumors will absorb more of one color and less of another different other color. And then I can compare with the database that I have, and I know based on this signature if that tissue is normal or if that tissue is a disease. So we have different studies showing that those are very reliable information, and just based on the light from that humans cannot see, but the machines can see and learn. They can figure out just by looking at something if it's benign, or if it's a polyp, or if it's a cancer. So here is an example for endoscopy where different type of alteration, let's say normal gastric mucosa or Barrett esophagus or cancer, they have different spectrums of different lights. When you use different colors, you can see differences. And then you can see on real time and make the diagnosis of a lesion just looking at it during surgery. So, and it's very easy to take this technology and add to the robotic platform. So during surgery, if you see a tissue and you don't know if it's tumor, where the margins are, you'll be able to see, well, the tumor is here and here is normal tissue. So we can just remove that particular tissue. Another interesting technology that it's being developed, and that's quite feasible. It's not so difficult. It's based on the gas that the tissue is producing. You can know if that tissue is tumor or it's a normal tissue. So this is it's a trial that's just aspirating normal smoke that we produce during surgery using regular cauteries. And during the smoke evacuation, it can say, and it can tell you, oh, this is smoke from normal tissue. Oh, this is smoke from tumor tissue. Or this is smoke from pre-invasive tissue. So based on this information, you can know during surgery, oh, now I reached normal tissue. So you remove the tissue, let's say you remove a tumor, and once you start burning around, the smoke that comes out of it, let's say come without tumor, so you know you have reached clean margins. So this is another technology that is being developed, and probably soon we'll start seeing in the ORs. So and it's easy to use it with the things we already have. So all those things, they are being added to the robotic platform, and we're going to see it working really, really soon. And how about the future? I'm going to show you some things that I don't think I will use them as a surgeon. So I don't think that's going to happen in the next 20 years because of all regulation. It could, most of them could. But because of all regulation and how hard it is to implement new technology in humans and all that, I don't expect that to happen really soon. But if you can have a self-driving car, if you can have a robot that can walk alone and overcome obstacles and do like crazy jumps and all that, as we are seeing, and you have all this technology for the robotic arms and all that, it's not hard to think that probably robots can also do surgery itself. What's the problem with that? It's all those other technologies that we are seeing in the real world, like self-driving or robotic platforms walking, they are collecting data it's widely available. So it's very easy to collect data from cars, from like walking robots. But for collecting data from surgery itself, it's not easy. And when all these machines, they learn things, they need to collect data. So this is like Facebook picture. This picture is like I did like 5 to 10 years ago. It was a family meeting, and Facebook, not fancy at all. They immediately recognized like more than 10 people in the picture, in the photo, based on their database. But that's why Facebook has such a huge database with lots of information, with lots of people, and it can, recognize things. But recognizing like blood vessels, anatomy, and all that, we don't have that much information. And that's why probably all those technologies we are seeing being developed that could be integrated using AI, they will take longer because data is the key thing. You need data to build those models with artificial intelligence and all that. And collecting data from surgery is not easy. I would say like 99% of the time we don't record the procedures. And when we record, there is no labeling, there is no information. So, and all AI models, you need to teach them. You need to show what that thing is. You need to say, oh, this is a vessel. This is this particular vessel. And it bleeds this way. Once you teach them, they start learning by themselves. But you need a very large database. And that's the issue with big data and machine learning in surgery itself. However, you can help surgeons to do diagnosis and to do exams and other things that we can leverage with machine learning and big data. But surgery itself, probably we won't see in the next 20 years. I would say we won't. But hopefully, once we made to integrate all those systems that we're seeing, we're going to see machines helping us to plan surgery, to give guidance. Let's say you are about to cut a nerve, you should not do it. It will tell you, well, this is the nerve you are about to cut, and then you're going to make the decision. So it will help you to make the decision. And finally, and probably 40 or 50 years from now, maybe more, I'm quite sure there will be autonomous surgery. As everything, probably. That's going to happen, that's for sure. I just don't know when. And hopefully that's going to take more than 20 years. I'll be retired, hopefully. But that's going to happen. That's for sure. If there is something a human can do, machines will learn and they will do it too. Also, you need to realize that it's so complex to take decisions. You have like genomics, we have tumor biology, we have patients' particular characteristics, patients' issues, wishes, and all that need to be considered. And that's why it's so hard for a machine at this moment take those decisions, and for us as humans to accept a machine taking those decisions. There are other ways to innovate in surgery. I would say if you work with improving access, that's something that you can work with. It's also innovation. There's also always room for reducing costs. So we need to keep looking at it and addressing disparities. So all that is also innovation. And we also need to bring those innovations to all patients, because as things get more technological, they are getting more and more expensive. And actually what we're seeing is that most of the people are not having access to those. And it will take longer to have those access. So we still need to work on that. And that's pretty much what I see as where we are going towards and what's happening and what's going to be the future. But I want to finish with a very quick story to tell you that you can innovate now with the tools you have. Sometimes you just need to look around. And then when you think about things that have changed the world, like iPhone, it was a really change. So I came from, there was no cell phone when I was like a teenager, when I was at med school. Cell phone, when I was finishing med school, I saw for the first time a cell phone, not even an iPhone or a smartphone. It was like a phone, cell phone, anyways. So, but when you think about those new things that changed the world, sometimes they were quite well-known concepts that were combined to create a new thing. So they had like those touchpads back then in the 80s, in the 90s, but there was some internet too. There was GPS, there was data processing, there was batteries, and the innovative thing and the genius part of this was combining those technologies to create these devices that we now use and changed our lives. So what I challenge you is to look around and see if there's, in the things that you know now, maybe if you combine your knowledge with the things that already exist, you can create something new. And I'm going to give you a very quick example how it may happen in medicine. So a few years ago, 10 years ago, I had this patient. She was a 26 years old lady, no children. She was a physiotherapist. She was engaged, and she had a rectal cancer. So traditionally, she would need radiation and then surgery for the rectal cancer. The problem is she was 25. Radiation causes ovarian failure. It's immediate. It takes like in weeks, you lose all your oocytes, and patients lost fertility. It also causes like a myometrial fibrosis, and the uterus becomes useless regarding bearing a child. So you cannot get pregnant after pelvic radiation. So usually those patients, they go to they need to do frozen embryos, they need oocyte vitrification, and it's expensive. Takes time. They don't want to wait for it. Most of them, they will lose their partner because, they get scared. They want to have kids, biological kids. So those patients, and they cannot get pregnant. They can froze their eggs, but they will need a surrogacy uterus. So that was a real problem. And there was no option for those women. So, but when we looked around for the techniques we have for other diseases, we knew from, let's say, cervical cancer that I could remove from patients, I could remove the cervix, I could ligate the uterine arteries, and the patient would keep the uterus because we remove the cervix and attach the cervix to the vagina. That's called a radical trachelectomy. And that's because the blood supply from the ovaries come from the upper abdomen, go along the gonadal vessels, enter the ovaries, and go to the uterus. So you can keep the blood supply of the uterus with the gonadal vessel, right? Okay. And we also knew from the 70s that I can put the ovaries of the patients in the upper abdomen to protect them against radiation. So let's say I have a cervical cancer. I could do radiation to the cervix. And if I remove the ovaries from the pelvis and I put in the upper abdomen, this is a flap, the ovaries will keep working. So this is old stuff. That's not new stuff. So we realized that, well, if I can remove the cervix and if I can mobilize the ovaries to the upper abdomen, why don't I, for those patients that have like other pelvic cancer, that the uterus is normal, why don't I just don't remove the ovaries in the uterus from the pelvis of those patients? They can get radiation then, and they won't lose fertility. And that's what we did. So 10 years ago, with the knowledge that we already have, we started this new procedure, which is called uterine transposition, which is pretty much mobilizing the uterus, ovaries, and tubes to the upper abdomen. You see, this is a rectal cancer. So we are mobilizing the uterus, taking it outside of the radiation field, keeping the gonadal vessels supplied to the uterus. So the uterus, ovaries, tubes, everything will keep working. And you see, we are sectioning the uterine vessels and we are detaching. This is the uterus. We are cutting the vagina, separating the vagina from the uterus. You see, we are mobilizing the uterus to the upper abdomen. This is the vagina after we suture it. Then we mobilize those vessels. This is the dissection of the gonadal vessels in the retroperitoneal area. And now what you see is the uterus going to the upper abdomen, and then we suture the uterus in the upper abdomen. That's very, let's say, primitive procedure. That's that's the thing we know back then. We used to attach the cervix to the umbilicus so patients can have umbilical menses while they wait for the uterus to be back to the pelvis. So those patients go to radiation. After they finish radiation, they come back and we put those organs back to the. So this is the uterus in the umbilicus, and this is menses while they wait for the uterus to go back to the pelvis. So they do the radiation, then we go back. Again, this is the uterus. You just detach the uterus and you put it back to the pelvis. So though these were knowledge that was there, we just combined different things that we already knew and created something new. This is a cervix suture to the vagina, and then we just reconstruct all ligaments. So sometimes what you see is use the knowledge that you have to build new procedures. And it was published like in 2017, and now we see there are more than 20 countries that have been done, and centers like the Memorial in New York are doing, and we have babies in different countries, different states, all over. And obviously, like innovation in medicine, it's a hard process. It's so easy to show the pictures and the procedure, and you don't show the patients and the behind the scene what's happening. But anyway, so you always need to think all these things when you are working with patients. So in conclusion, innovation is a very hard and long process. Technology is the engine that drives us to surgery. That's for sure. We are moving from a very, let's say, human-made thing to a more machine-made procedure. And the robotic platform is the way to go. I have no doubt about it. And what we are seeing now is the robotic platform incorporating all those new technologies and building something better. But however, innovation can also be done with the tools we have. So look around, stay open, and try to see. Sometimes innovation can be just right in front of you. Thank you so much.
Thank you very much, Dr. Ribeiro, for that really wonderful presentation. Any questions? So when you do uterine transposition, that's clearly very, very fulfilling. And I see how it has touched a lot of people. So how do you determine patient selection criteria?
Yeah, that's a good question. Mainly, you need normal reproductive system. You need a normal uterus. You need normal tubes and ovaries. That's the first thing. Patients really need to have the desire to preserve fertility. Although we started to do it in kids, like before we were doing just in adults, and now we are seeing 8-year-old kids, 6-year-olds, so they cannot have this judgment. But if we understand that something up, we need to preserve this, that's something you may consider too. And then usually we don't select patients with very advanced cancer that the mortality rate would be too high, because you don't want to also to have like a pregnant patient with cancer or with a recurrence. So we usually select those patients with tumors that can be cured, and the patients that want to get pregnant, have a strong will to get pregnant, and they don't have any other options that are feasible. Because even frozen eggs, you need surrogacy uterus, and most of the patients, they will just give up of getting pregnant when they need surrogacy. So it's a combination of not having a normal reproductive system and a tumor that can be cured.
Okay. So as I understand it, this is a two-stage surgical approach.
Yeah, so you can do it with robotics, you can do it with laparoscopy, and there are even cases reported done opened.
Okay.
But yeah.
All right. Thank you. Any questions?
Sure, yes. Dr. Rivero, that was a very amazing talk, actually. The robotics section was fascinating and it really felt like I was in some sort of, futuristic Hollywood film, watching what has been developed up to now. So I guess I'd like to go back to the last statement you mentioned about autonomous robotic surgery, which I guess you suspected will happen, but I guess some time in the later future. They mentioned that data collection was one of the limiting factors, large data set collection. So that I'm sure something like doing assisted robotic surgery, you could probably, equip some sort of data collection system there and start large data set collection through, regular those types of surgeries that happen and adapt them to some sort of AI system. But I guess the real question is, like, how do you feel it's more of a political question. How do you feel the medical industry and even the insurance companies, how do you think that will change the whole environment? If we expect this to be happening sometime in the relatively near future.
Yeah, I think at safety, it's always a concern. Once you prove it's safer to use the robotic platform, and these or that technology, the insure companies and the doctors themselves, they will push harder to adopt that technology. Patients usually they don't know. Now it's way more. I would say there is a strong marketing behind it and all that. So it's very hard to tell now that you need to adopt this or that, because the benefits are not very clear. But once the benefits become clear, the industry itself and the insurance companies, they will start pushing doctors to use those technologies. It's going to take a while, though. I don't think that's going to be in 1 or 2 years. Usually those things, they take longer because it's the human factor. We don't like change, so we try to keep things as they are. But I think as soon as the cost drops a little bit and you prove it safe, it's naturally that's going to happen. And about the data collection, that's an interesting thing because I agree 100%. You can collect data from the robot, you can collect. Yeah, Johnson & Johnson started a project, it's called CSET. So if you do surgery, you can go. It's like a Facebook for surgery, right? So the thing is, they want people to go there, upload your cases, and they help you to make comments and things like how to improve your procedure. That's the main thing of the platform. But actually, that's about data collection. They are trying to collect data from different
Deal,
surgeons.
yes.
That's for sure. And the only mistake they made, they want you to pay to upload your
Oh,
cases. Then it stuck.
that's
So
crazy.
I
Yeah.
don't know how it's going, but the idea was quite good. So they would like to have this environment where anyone could just upload surgeries and have comments, and other people would comment on the surgeries itself. But once they say no, you have to pay for it, then I would just upload on YouTube because it's free.
Yeah.
And yeah.
Thank you.
So what you showed at the end, different centers, different countries performing what you pioneered, which is really brilliant. Have there been clinical trials or that?
Yeah, I didn't enter the deep part of the uterine transposition. Maybe another time we can do like a lecture on uterine transposition. We did a prospective trial, a feasibility trial, eh, uh, and it was published 1 year and a half ago, and with 8 patients. So we prospectively evaluate the complications in fertility preservation and also the rate of patients getting pregnant. And it's quite hard to access fertility rate. What we know from those 8 patients is 3 of them tried to get pregnant. 2 of them got pregnant spontaneously. So that's for the first time in history, patients with pelvic radiation are getting spontaneously pregnant. And they had healthy babies. So we know it can happen. The problem with those trials is that's a limited number of patients, not a lot of them. And you need to wait until they want to get pregnant because some of those patients, they were like 18 years old and they don't even,
Yeah.
want to get pregnant at all. So we need to wait more. And
Mm.
now we're seeing centers like Memorial, they have like a big series now. I think they have more than 10 cases now. And countries like India and Russia doing lots of cases. So probably soon we have more data on that.
Okay, great. Any more questions?
Just one more. It's about the autonomous surgery. So if you have a robot out there that's able to do these surgeries, like how, I mean, should that not like shake up the medical industry a little bit? If you could replace surgeons with just robots, that's something I would imagine not get so much credibility from the medical community, no?
Yeah, actually, it will depend. I think they will start with simple procedures or procedures that can be very, very straightforward or that can rely on technology. But let's say we may do, I don't know, like small skin procedures, and then we
Mhm.
go move on.
Mhm.
Definitely removing the surgeon could be very beneficial in terms of cost. Depending on the country. Some countries like Brazil, not at all because it's so cheap. But in US, I guess
Mhm.
so. They would love to like remove this cost because if you think about it, a robot in US would cost like I don't know, roughly $1.5 million, and it,
Mhm.
it can work like
Yeah, many.
as many hours as you want. And a
Yeah.
surgeon costs 600,000, 500,000.
Mhm.
So yeah, sounds good to me. Good business.
Uh,
So thank you very much, Professor Ribeiro, for that really wonderful presentation.
Thank you.
Uh,
Thank you so much.
and thank you everyone for attending the seminar. And Enjoy the snow outside.
Yeah.
Yeah. Bye, everyone.
Bye-bye.
Bye.
Thank
you.
you.